Hello and welcome to GI 101. My name is Dr. Adriana Lazarescu and I am a gastroenterologist at the University of Alberta Hospital in Edmonton. In this episode, I sat down with Dr. Dan Sadowski to talk about chronic constipation. This is a very common problem and is a frequent reason for patients to consult with their doctors. We have covered this topic previously in episodes 3 and 4 of GI 101, and I wanted to find if there is anything new in the treatment of this condition. Here then is my conversation with Dr. Dan Sadowski. Hi Dan, welcome back to GI 101.
Hi Adriana, it's really great to be back again.
Before we get to the treatment of constipation, perhaps you could give our listeners a brief overview of what we mean medically when we use the term constipation.
Okay, sure. So clinically, we define constipation as someone who has less than 3 spontaneous bowel movements per week. But I need to point out that reduced stool frequency is really only one part of the problem. There are a number of other symptoms that can make patients feel uncomfortable, and that's the sensation of hard, dry, or lumpy stools, the requirement to force and strain in order to evacuate stool, and the sensation of incomplete emptying after a bowel movement, as well as the feeling of bloating and abdominal fullness. And by chronic constipation, we mean constipation symptoms that are frequently present for at least 6 months.
I understand that there are different types of constipation. Can you talk about them and why it is important to identify which one a patient has?
Yeah, so not all constipation is the same. There are 3 main clinical syndromes that can present this way, and the 3 types of constipation are chronic idiopathic constipation, irritable bowel syndrome with constipation, and then outlet type constipation. And each one of these 3 types have a different clinical presentation, and it's important to identify each of them at the bedside by taking a focused history. And chronic constipation and IBS-C are by far the most common constipation subtypes, and we can tell the difference between these two with the presence of abdominal pain. That is, abdominal pain is really the presenting complaint often in patients who have irritable bowel syndrome with constipation. Now, it's true that slow transit constipation patients have discomfort when their bowels are really full of stool, but pain is not really their primary concern.
What about outlet type constipation?
Yeah, so this syndrome is less common than slow transit constipation and IBS-C, but it's important to identify as the treatment pathway differs considerably. And this subtype occurs when there's something anatomically wrong with either the distal rectum, the anal sphincters, or the pelvic floor. And causes of disordered defecation are things like dysynergic defecation, rectal prolapse, rectocele, and so on.
Are there any features on history that might suggest this diagnosis?
Yeah, and this is where the history is really important with the patient. And this presentation, patients will often have difficulty passing even liquid or soft stool. And these patients often spend a lot of time on the toilet, forcing and straining in an attempt to defecate. And they may notice prolapse of rectal mucosa. And they may also try various maneuvers, such as pressing on the side of the anus or putting a finger into the vagina and pushing posteriorly. And some patients may even attempt to open or straighten the anal canal by inserting an object, such as a pencil.
I am sure that many patients might be embarrassed to talk about this type of information. I wonder how often this diagnosis is missed.
Yeah, I think you're right. I think we underdiagnose this, and in my experience, many patients have the symptom for many years before the penny drops. And so I think maybe this would be a great topic for a future episode.
Good idea. So let's return to chronic idiopathic constipation and irritable bowel syndrome with constipation. I know that we covered some of the treatment aspects of these in a previous episode, but for our listeners, can you talk a bit about your treatment approach?
Sure. So first, it's important in the clinical assessment to look for red flags. And these are symptoms, clinical indicators that suggest that a serious disease such as colon cancer or inflammatory bowel disease might be present. And red flag symptoms include things like new onset constipation after age 50, or rectal bleeding, fever, weight loss, or nocturnal symptoms, or a family history of colon cancer or inflammatory bowel disease. And in these situations with these symptoms, you might want to proceed to colonoscopy before embarking on empiric therapy. Secondly, there's a number of potential secondary causes of constipation that need to be looked for in the history. And these include lifestyle factors like low fiber intake or low physical activity, certain medications such as opioid analgesia, and medications that have anticholinergic side effects. And then we look for endocrine factors such as diabetes or hypothyroidism. We look for things like endogenous depression, eating disorders, and neurological conditions such as multiple sclerosis or Parkinson's disease.
Thanks for that. I should alert our listeners that we covered opioid-induced constipation in a previous episode of GI 101. Let's now talk about treatment.
Okay, so I guess I can't talk about treatment without talking a little bit about lifestyle, because I do think this plays an important role in chronic constipation. And so some very simple things like eating 3 regular meals per day. And I think in our culture today, people often are too busy for breakfast and they skip lunch, and then they end up consuming all of their calories at the end of the day in one meal. And so I do think eating smaller, more frequent meals 3 times a day is helpful to stimulate colonic peristalsis. And then exercise. I think regular exercise as well plays an important role here. But beyond that, many patients need some help with their bowel movements. And for that, we have a variety of laxatives, such as stool softeners, osmotic laxatives, stimulant laxatives, and then also some newer prescription medications as well.
Let's talk about each laxative type in turn. Tell me about stool softeners.
Right. So stool softeners such as Ducosate or glycerin suppositories, and these essentially work as lubricants, easing the passage of the stool. And many patients take these, but my experience is that they're really useful for mild constipation only. And certainly by the time patients with constipation severe enough to see me as a specialist, they've tried those and have failed this laxative type already.
Osmotic laxatives are very popular. How do they work?
So osmotic laxatives as a class are things like polyethylene glycol, or PEG 3350, also milk of magnesia or lactulose. And all of these work by increasing the water content of the stool, making it easier for colonic peristalsis to produce forward bowel movements. And I guess my favorite are the PEG 3350 ones, sold in Canada as Restorelax and Laxaday, among others. And I use these laxatives for both slow transit constipation and IBS-C. Several things to keep in mind here. One is that they work best if they're taken daily, as opposed to waiting until the constipation is severe. The other thing is that the dose can be increased depending upon response. And so normally I start patients out with, say, Restorelax, 17 grams once daily. And after a week or so, if there's no response, I ask them to increase that to twice daily until the stools become soft and easier to pass.
What about stimulant laxatives? I think that there are a lot of misconceptions about this class of laxatives.
Yes, so stimulant laxatives, things like Senna and Cascara, and they're usually sold over the counter with a variety of names, also found in herbal products, cleansing teas, for example, and often these products do contain Senna and Cascara as well. And they're called stimulants because they actually stimulate the colon to contract, and they produce a peristaltic contraction. And one of the things that you need to know about these is that they can actually produce cramping pain because they actually do produce colonic spasm. And so if you have IBS, perhaps a stimulant laxative is not the best choice for you because it might make the pain worse. Having said that, I do use stimulant laxatives for slow transit constipation, often in combination with an osmotic laxative. For example, I'll place someone on a daily dose of PEG 3350, and then perhaps have them take a Dulcolax tablet every 3 days or so if they feel particularly full or uncomfortable.
It is also important for our listeners to know that this class of medications can have long term effects on the bowel if used regularly. For example, long term use of senna can lead to something called cathartic bowel, where the bowel is used to requiring senna in order to move, and over time becomes slower and slower, requiring more and more medication. It is okay to use these medications on an as needed basis or every few days, as you mentioned, but again, long term regular use is to be avoided. Let's move on to the newer medications that are available for constipation, and these are by prescription. One of them is called Linaclotide, which is sold under the brand name of Constella in Canada. Can you tell me a bit more about Linaclotide, Dan?
Right. So Constella, also known as Linaclotide, it's been available in Canada for the past 8 years, and it's been approved for both chronic constipation and IBS-C. And linaclotide is what we call a luminally active medication. That is, it doesn't really get into the bloodstream. It acts on the luminal surface of the intestinal epithelial cells and exerts its effect that way. And technically, it's a guanylate cyclase agonist. And when it binds to intestinal epithelial cells, it increases intracellular cyclic GMP, which stimulates secretion of chloride and water into the intestinal lumen, which improve bowel movements. And at higher doses, it also reduces the activation of colonic sensory neurons, reducing pain sensation from the gut. And in clinical trials, this medication significantly improved the number of complete spontaneous bowel movements per week in constipation sufferers.
Great. So practically speaking, how do you use this medication?
Yeah, so it comes in 3 doses, the 72 microgram, 145, and 290 microgram tablets. And I usually start at 145 micrograms and then instruct the patient to take it once daily on an empty stomach half an hour before breakfast. And the main side effect of linaclotide is diarrhea. And so I always tell patients for the first few days to take the medication when they know they're going to be close to a bathroom.
So when would you use the other 2 doses?
Right. So the 72 microgram dose, if your patient has diarrhea at the 145, you can step down to the 72 microgram dose, and often the diarrhea will improve. And then the higher dose, the 290 dose, you can step up to that if the lower dose is ineffective, or if the patient is having abdominal pain. So patients with IBS-C will often need that higher dose to relieve constipation and the abdominal pain problem.
A new secretagogue, also a guanylate cyclase agonist, became available in Canada recently. It is called Pantide and goes by the trade name of Trulance. Can you tell me a bit more about that?
Right. So Pantide, also approved for use in chronic constipation and IBS-C. It also works on the luminal surface of intestinal epithelial cells. And as you mentioned, it's a guanylate cyclase agonist. And the dose is 3 milligrams, and it's taken once daily.
So if the mechanism of action is the same as linaclotide, how is Pantide different?
Right. So yes, it is a guanylate cyclase agonist, but Pantide is actually pH sensitive. And so because of that, it's only active in the small intestine. And because of that, the incidence of diarrhea in the clinical trials was less than linaclotide. As well, it doesn't have to be taken on an empty stomach. It can be taken at any time.
The most recent medication that became available for chronic constipation is Tenapanor, which goes under the brand name of Ibsrela in Canada. Let's talk a bit about this medication.
Right. So Tenapanor, also indicated for CIC and IBS-C, also luminally active. That means it has very little systemic absorption. It works a bit differently, though. It works by inhibiting the sodium proton exchanger, NHE3, on the luminal side of intestinal epithelial cells. And this blocks sodium reuptake in the intestine, thereby causing net water flow into the bowel. And the dosage for Tenapanor is 50 milligrams twice daily.
Thanks for that summary, Dan. It sounds like we have a lot of options for our patients with chronic constipation right now, including prucalopride, which is an older medication that we discussed in a prior podcast. How do you choose between these therapies and what order do you use them in?
Yeah, so that's right. We now have the luxury of a number of different, very effective treatments for chronic constipation and IBS-C. And once again, I start with lifestyle. And then, as I said before, I'm a big believer in the Osmotic laxatives, PEG 3350-based laxatives. And then beyond that, there are the prescription medications that I talked about. And we're in a situation now where there aren't any head-to-head clinical trials between these four that you mentioned. We don't know which one is superior to another. And so my choice really depends upon, first of all, the patient's insurance coverage, because these medications are expensive, and then their tolerance or intolerance to various side effects. And so it's a little bit of empiric, a little bit of trial and error, and sometimes switching between classes of these medications till a patient finds effect from one.
I totally agree. I would also say that nothing works in everybody. So you do have to do some trial and error to find the best agent in a particular patient. Thank you very much for that review, Dan. Thank you also to our listeners. Please consider subscribing on iTunes and on our YouTube channel and give us a rating. Stay tuned for more episodes and see you again soon. Bye.
Bye.